Professor Schuppan holds a double position of Professor of Gastroenterology and Hepatology at both the University Medical Center of Mainz and at Harvard Medical School, where he has been teaching for a long time. And he has a strong research interest in liver inflammation, in fibrosis, and in NASH, among his other innumerable interests. I mean, he's been one of the most productive scientists in many fields. And definitely, he now will try to clarify which endpoints are clinically relevant for trials in non-alcoholic steatohepatitis. Detlef.
Thank you very much, Professor Craxi, for these nice introductory words. So we have already talked about this, the problem of NASH, so I can go over that very quickly. And NASH is tightly associated with the development of hard endpoints. One of the major hard endpoints is cirrhosis. And cirrhosis in NASH incurs a high risk for decompensation and HCC, apparently faster than in hepatitis C cirrhosis. But as we have learned, the natural history of fatty liver is difficult to predict. So what about one major endpoint, which is cirrhosis, which of course is prone to decompensate and to develop in HCC or go to liver transplantation. These are the hard endpoints. Even cirrhosis for the regulatory authorities is considered some kind of hard endpoint because it incurs this high risk of decompensation and liver cancer. What about then non-cirrhotic fibrosis, let's say stage 2 or 3? This in itself is not a hard endpoint. However, if we have measures to show that the disease will progress rapidly towards cirrhosis, this can be considered a fibrogenesis endpoint. But for that, we need non-invasive markers. So if we recur to the endpoints conference that was held in 2013, which is summarized in this paper in Hepatology, so currently, the consensus on clinical trials is that we still need histology as the major endpoint, although we want to get away from that for good reasons. And the major endpoint, of course, is, as we have heard in several studies mentioned, the resolution of steatohepatitis with no worsening of fibrosis and a minimum 2-point improvement in the NASH score. And of course, we have some other ancillary parameters like improvement of steatosis, which in itself is not dramatically relevant, and also some very bad surrogate markers like ALT, especially when we look for signals in short-term and low-numbered trials. However, this all is focused on liver pathology. And of course, it's not liver pathology alone, although it's very relevant. This is just to show you again the major criteria for the NASH score. And currently, there's still a discussion. What would we define as overt NASH? Would it be just a NASH score of at least 5? Or would we like to include 4 or even 3? But then if we include the lower grades of inflammation, although patients incur a high risk for progression, as we have heard before, then we also have a significant placebo effect, as outlined very nicely by Dr. Yunusi. And of course, separate from this inflammatory score, we have the fibrosis score, very similar to the score for hepatitis C in a way. However, we have to bear in mind that biopsy, especially in NASH, is highly prone to sampling variability. And 2 larger studies, one performed also by Vlad Rațiu and colleagues, showed that the sampling variability with sizable biopsies from one liver is very high in terms of 1 stage out of 4 difference of fibrosis, about 40%, 2 independent studies. So in terms of fibrosis, but also in part inflammation and ballooning, we are left with a high sampling variability of the tiny biopsy. We have heard about the increase of obesity, not only in the US, as shown here, which has doubled or tripled in the last 20 years, so the colors have changed dramatically in the States. The important finding is that this goes hand in hand with type 2 diabetes. So you have a completely parallel development. Those states where you have a high rate of obesity, there you will also find a high rate of type 2 diabetes, 2 to 3-fold compared to 20, 25 years ago even. And this occurs in any kind of developed and developing countries now. So the other major endpoint we have to have a look at is the metabolic syndrome, which has been alluded to before. And the metabolic syndrome, with all its cardiovascular mortality and morbidity, is defined as visceral obesity, as a fasting glucose, which is elevated, or insulin resistance by glucose tolerance test, hypertriglyceridemia, and a low HDL, and hypertension, which is really a very rigorous criterion here with 130 to 85. And NAFLD patients, not necessarily the NASH patients, have at least one parameter in the majority. And about 1/3 has 3 of these parameters, and that's tightly associated with the metabolic syndrome and cardiovascular mortality. So when we look at endpoints in clinical trials, we have the general endpoint, which is alleviation or treatment of the metabolic syndrome and the associated diseases like type 2 diabetes and also cardiovascular mortality in terms of atherosclerosis and heart disease. And we have the slightly more specific liver endpoint, which is mainly fibrosis, especially cirrhosis. And this, again, is tightly associated with the liver inflammation. But there is quite a few data that the cardiovascular morbidity and mortality develops much earlier than significant fibrosis in NAFLD and NASH. And so it may be at least as important as advanced fibrosis to be treated with drugs or lifestyle modifications. And this is just one example, and there's many, many studies showing that the metabolic syndrome definitely increases as measured by intimal thickness in the carotid artery in relation to the degree of hepatic fat and inflammation or in relation to the degree of fibrosis. And there are several studies showing this correlation. And if you now compare somewhat matched, this is not completely matched in terms of BMI, because you see that the BMI in the NASH group is the highest, but it's not dramatically high, it's 28. And these are other groups with chronic liver disease, hepatitis C and B, that the intimal thickness is highest in the NASH group, which is independent if certain calculations are done from the BMI. So these were relatively lean people from Italy. And already going towards biomarkers, cardiovascular mortality and morbidity can be predicted by certain biomarkers, and potentially also in the future in clinical studies by a combination of these markers. And some of these are listed here again in relation to the stage, fibrosis of NAFLD NASH. You can see here that there is an increase of highly sensitive CRP. It's not significant between stage 0 and 1, and there's low numbers of patients, but there's a clear-cut trend, and the trend is highly significant. And PI1 plasminogen activator inhibitor, or also adiponectin, which is inversely correlated, and fibrinogen, which is again correlated with the degree of fibrosis, which again is somehow correlated to the degree of steatohepatitis. So there's a tight link between what's happening in the liver and what's happening in the periphery, especially the adipose tissue, which is shown here, which, as demonstrated before, is really, in terms of the visceral adipose tissue, it's a bomb for pro-inflammatory cytokines, which worsen the metabolic situation, not just in the liver, but also in the periphery, by favoring fat accumulation, and especially by favoring the wrong handling of the fats in terms of an enhanced release of free fatty acids and significant hepatocyte lipoapoptosis, which is associated with this insulin resistance, free fatty acids, and the wrong handling by the PPARs and certain other factors. So this is linked, but it's not completely overlapping, because we also know that NAFLD and NASH is an independent determinant of the metabolic syndrome and cardiovascular risk factors. So if you have the same group, one group without fatty liver inflammation and another group with fatty liver inflammation, they have the same BMI, the same factors, then the ones with the fatty liver inflammation have a much worse cardiometabolic outcome and parameter setup. So this has been alluded to, and of course everybody with a clear mind would say that this treatment pyramid definitely has to be addressed mainly with diet and lifestyle changes. This, in a way, would be the wonder drug. but everybody knows that this is difficult to achieve in a very significant proportion of patients, and that we would need at least adjunctive therapy for a large group of patients to get on the right track. And this is then the pharmacotherapy and somehow the last resort, but only indicated for very advanced obese patients' surgery. And in a way, this is very much linked. We have talked about the microbiome, but also about overfeeding and eating the wrong stuff. So we are what we eat, not only in terms of fatty liver disease, but many other diseases. And of course, then you would prefer not to eat a fatty person. And so this is just one slide about general pharmacological therapy. So this comes first because overweight, obesity is highly associated, of course, with fatty liver disease. And then you have additional factors, second hits too, which we don't have time to address, that cause enhanced oxidative stress, lipoapoptosis, fatty liver inflammation, and then fibrosis, which is tightly linked to hepatocyte lipoapoptosis. And of course, there are certain drugs and measures. And if we have just these, I think the most important drugs, at least for the liver, are here. These are antifibrotics, which have been shortly discussed, and cytoprotective anti-apoptotic drugs might have a significant role in alleviating the steatohepatitis, at least for the liver, and might have a secondary effect then on the metabolic syndrome. So if we talk about fibrosis, just a couple of slides before we come to surrogate markers and endpoints again. Of course, if you treat fibrosis, you want to inhibit the progression towards cirrhosis, and you want to induce, if possible, a reversal of advanced fibrosis, that means cirrhosis. And in cirrhotics, an antifibrotic therapy should lead to an improved liver angioarchitecture, and subsequently liver function, a lower incidence of HCC, and a reduced morbidity and mortality. We know that this is possible in viral hepatitis, especially for hepatitis B, but also very likely now for hepatitis C with efficient therapy. And this is just not trying to repeat anything, but this is specific antifibrotic drugs. And there's, apart from the study that had been just discussed with Dr. Yunussi, there are certain other drugs in the pipeline for fibrosis, for NASH, but also for other fibrotic liver diseases. And just to show you that there is quite a few of these drugs already in phase 2 clinical studies, and there's also novel drugs with certain promises that you might not have heard about, and all these are being discussed now for the treatment of fibrosis, and especially also changing inflammatory cells, and the anti-chemokine receptor drug that was discussed before belongs to this category, but also the so-called macrophage polarization is very important in antifibrotic treatments, and there's many humanized antibodies and antagonists already, which have been developed for other indications, for asthma, for example, allergic diseases. So what about fibrosis assessment? So we, of course, have the biopsy, which I have shortly discussed with a high sampling variability. We have serum fibrosis markers. We have transient elastography, and we have quantitative imaging. I will just discuss a few of these. So what we would need most is validated markers of the activity of the progression of the disease for short-term follow-up and efficacy assessment of drugs. And we would ideally also need some kind of gold standard, a quantitative imaging of the activity of the fibrosis progression. So if you just summarize in a single slide what is the current state of the art. The current serum fibrosis markers have been validated in large clinical studies, mainly for chronic hepatitis C, against liver biopsy as a static, so-called tarnished gold standard. However, if we combine these serum marker panels with transient elastography, at least for clinical decision-making, and this is important for stratification of NASH patients, we can definitely very significantly improve the staging and the prognostic assessment of patients in terms of progression. So there is also certain markers that are predisposed to be activity markers, and these are currently developed and evaluated. I will just show you short examples of this. And what we definitely need, and what all the regulatory authorities would like to see, is more sensitive and specific surrogates for not only fibrosis stratification, but especially the progression of the fibrosis, the fibrogenesis, especially for proof of concept studies in NASH, but also other liver diseases. So the current serum fibrosis markers are either the so-called direct tests. These are markers directly related to the extracellular matrix, to the fibrotic tissue. And then there is these indirect test panels, parameters related to liver function, like the fibro test. And then there is tests combining 1 and 2. And the big question still is, are these only static, not very good markers of the fibrotic tissue, or are they rather dynamic, which would be more logical? So if we now look at the comparison of biopsy with these marker panels, and there's quite a few panels in this nice study on patients with chronic hepatitis C, and just for making the differentiation between mild or no fibrosis and significant to advanced fibrosis and cirrhosis, all these marker panels perform in a comparative way. You can see here the area under curve for predicting these two groups are very, very similar. Whatever kind of direct, indirect, or mixed marker panel you use. So, and they have an area under curve around 0.8 to 8.5, which is not dramatically good even for this crude differentiation. And one of the problems is also that intermediate stages of fibrosis around F2 are very difficult to predict from the lower and the higher stage F1 and F3. So the predictive accuracy is lowest around F2, is very high when there's no fibrosis, and is quite good also in terms of cirrhosis. So what about novel markers? Novel markers for fibrosis definitely should rather reflect the balance of extracellular matrix, ECM degradation, and biosynthesis. And this is just showing you a panel which we are also going to evaluate in the new NASH European initiative, the EPOS, Elucidating Pathways of Steatohepatitis, somewhat a follow-up of the Flint Consortium. And there is certain biomarkers that are direct markers that are related to the metabolism of certain collagen subtypes, measuring certain fragments which are either correlated with biosynthesis of this specific collagen or the degradation of this collagen. And then there's other markers that we developed both in Boston and here that are just found by proteomics of rapidly progressing animals in this case, and regressing animals. So there are fibrogenesis and fibrolysis markers which we are putting on an assay basis now. And just to give you one example that there is really a good hope that we are arriving at very good markers. This is a protein which is processed by an enzyme. So it's a collagen, for example, and it's cleaved here, either producing degradation fragments of that protein being related to removal of excess matrix, or producing from a precursor form a mature collagen which is deposited. And just showing you one example, these are 3 groups which we have recently investigated, not published yet. These are post-transplant patients which have, or who have been followed up for up to 5 years, up to 3 years here. And we have subdivided groups of 40 patients into the fast progressors, intermediate progressors, and the non-progressors. And as you know, post-transplant, many patients progress, or progressed at least in the past, very rapidly, developing cirrhosis within 1 to 3 years. So these are the fast progressors. And these are, let's say, the patient cohorts which should give us clear-cut signals in terms of fibrosis progression. And here what we measured was a marker developed by Nordic Biosciences in Denmark. And this is clearly related only to the deposition of collagen type 3, which is one of the major fibrillar collagens in scar tissues in the liver. You can see here that if you go to the, if you differentiate the very fast progressors versus the non-progressors, and have also a look at the intermediate stages, you really have almost 100-fold increased risk with a high serum levels to progress with this specific marker. And just the last but one slide, something that is also in development and which could yield a so-called gold standard of fibrogenesis, not just fibrosis, is targeted imaging. Targeted imaging means you have a small molecule that detects a certain receptor on actively fibrogenic cells, like the myofibroblasts, you have these receptors, for example, the platelet-derived growth factor receptor beta, or the fibroblast activation protein. Also, on activated progenitor cells, you have the integrin alpha V beta 6 exclusively being upregulated and expressed. You can address these with small molecular ligands, couple it to a radioimaging agent, and then after injection quantify the amount of fibrogenic cells in the liver. On the other hand, you can also use small collagen-binding peptides that bind to the collagen that is there, and also image the quantity of collagen. This is currently very hotly in development, serving potentially as a good gold standard. And so how would a study look like? Of course, future studies and treatments, optimal treatments for advanced NASH, for example. Of course, you would first risk stratify the patients, which can now do fairly well with the FibroScan, even without biopsy and some serum surrogate markers. You would then look at the associated comorbidities, which in a way is already done, but there's specific also serological markers, potentially for lipoapoptosis. I haven't mentioned cytokeratin 18, which could be one of the markers, but there's more. And you would also look at atherosclerosis markers, and I've shown you a panel before that could be used all together. And then you would look at global liver function, and for that we would also need more reliable tests. We don't have good liver functional tests. And in advanced patients, of course, portal pressure, but also for that we would need better surrogates, because everything is invasive and not easily reproducible between centers in terms of portal pressure measurement. And then, of course, with these selections of biomarkers, you would follow up the patients, even in the short term, low-numbered patients, and you could really test certain drugs quickly and maybe even combinations. And it would go towards a personalized dosing of drugs, which you would then recognize within days to weeks for dose adjustment or even add-on drugs for a combination therapy. So that would be the ideal future scenario, and I'm pretty sure we'll arrive at that. And the FDA and the EMA, they want plausible, reliable, and on-target surrogate markers of disease, activity, and progression, in addition to the current biopsy-based requirements. And this is just a summary, and then we come to the end. So progression to cirrhosis and liver cancer is the most important hepatic endpoint in NASH. And NAFL, the fatty liver, is a necessary but insufficient precondition to develop NASH and cirrhosis. And this NASH, of course, is differentiated from NAFLD also by the uncontrolled fatty acid handling and resulting hepatocyte lipoapoptosis and consequent fibrosis. And of course, we don't have to lose out of sight the metabolic parameters which occur early, even in fatty liver, with mild inflammation. And this is the major morbidity and mortality which we would have to address in certain patient populations, which is conditioned also by the liver disease. And I've mentioned the better personalized serum markers, but also imaging methodologies for hepatic fibrosis and inflammation, especially fibrogenesis. And the ideal drug combination targets both the metabolic problem and the fibrosis if we have advanced patients. Thank you.
Thank you. Well, we don't have much time. In fact, we don't have any time left at all, but we can only take one question if there is any burning question.
You mentioned that vitamin E is actually recommended. This is the case by the ACLD guidelines. But there are also some data regarding the side effects of vitamin E for stroke and prostate cancer. So what do you think? We should use it in patients with NAFLD with diabetes?
In terms of vitamin E, of course, that was one of the major concerns that the guideline committee actually looked at. I was on that guideline committee. And there are really two issues. One, when you look at the risk of associated with vitamin E, we're talking about a completely different patient population that were significantly at high risk for cardiovascular sort of diseases that exist. The other thing is that personally, myself and a lot of my colleagues, we don't start with 800 NASH units that was used in the pivotal study. We start with lower dose. And if you get basically, and what do we use to look at efficacy? If you get normalization of liver enzymes, that's good enough for me, and I don't go up to 800 NASH units per day. But that is what we do only for non-diabetics who have histologically proven NASH Part of the problem is that we have nothing else to offer. Maybe this is our own, we are treating ourselves rather than the patient, but that's what it is.
Thank you very much.